Good morning, everybody. Good afternoon, good evening. I think probably good night to some of you as well. Uh, Thanks for being here today. My name is Hank Worth. I'm one of the pediatric cardiology fellows at Cincinnati Children's. And I just wanted to kind of show my appreciation for everybody signing on uh, today. And this is a case series that we call Cardiology Across Continents. This is an interactive case-based learning series. And really the purpose of this is to kind of foster intercontinental, international collaboration between trainees on discussing particularly interesting and particularly problematic cases in pediatric cardiology, and with a main focus on kind of eliciting the differences in how different cases are managed and worked up in different settings with different resources. And so that's kind of the framework that we're working from here. Just to move forward a little bit, so this has been going on for a couple years now. We've had quite a good collaboration with the team at Amrita, who's on the call today. But we also have worked with teams in Brazil at Recife. We've worked with a team at Texas Children's, a team at the National Pediatric Hospital in Mexico City, and now today, for the first time, a team from Children's National in Washington, D.C. We also have had some collaboration with the team at the Uganda Heart Institute, and they are on the call today as well, because this is their patient that we're talking about. Just to go through the format very quickly, so this is a webinar format. Really, like I said, we get two partnering institutions, and the idea here is to identify a challenging case from one institution, and then they pass that case details along to the next institution, and that place will kind of come up with a proposed management plan. Again, with the idea being that we want to really highlight what differences in management might occur between institutions where there's well-resourced kind of availability versus institutions where resources are a little bit less available. So during the session, one team will present the case details, and that'll be a combination of Amrita as well as some of the team members at Uganda Heart Institute. And then we'll pass it to Children's National, who will present somewhat of a proposed management plan. And then we'll talk about patient outcomes. This case today is a little bit tricky because I think we kind of as a whole, there's still a little bit of mystery about what exactly is going on, and that is certainly affecting the proposed management plan. And just to kind of mention, this is, like I said, an effort that's been going on for the past couple of years now, and we've had some success breaking through with publication on this. And there's always, I think, an interest in writing up some of these cases that are particularly interesting as case reports. So if anybody is interested, we always certainly invite collaboration. And this is just a little bit of a carrot at the end of the stick here, just to show that we would love to have people who have interesting cases send some forward to us, and we're always looking for new things to talk about. During this time, we certainly do want audience participation. I think what I'll ask is that if you are able to, and if you have questions, to put them into the chat, and I'll try to monitor that as we're going through. You can certainly raise your hand as Dr. KK talked about, but perhaps save interjections until there's a good pause in the discussion. And we'll have time for discussion at the end as well. And so moving on to today's case, this is a case about an 8-year-old female. She presented with severe mitral regurgitation and what's looking perhaps like a persistent hyperinflammatory state of perhaps unknown precise etiology. The team members here might disprove me on that. And again, the case originates from actually two institutions. One is Uganda Heart Institute in Kampala, Uganda. This is where that patient has primarily been taken care of, but there's a referral center at Amrita Institute of Medical Sciences, who's on the call here, who have also been intimately involved in this patient's care. And then the partner institution here is Children's National Heart Center at Washington, D.C. And just to introduce a few people, I think they will already, or I would ask you to introduce yourself too, but from the Amrita team, I know we have Dr. Selvam, who's a pediatric cardiology fellow. We have Dr. Sasi Kumar, who's an associate professor of cardiology, and Dr. Krishna Kumar, who is a professor of pediatric cardiology and division chief there. And then from the Children's National team, we have Dr. Yona Puelo, who is a pediatric cardiology fellow, Dr. Kelsey Brown, who is an advanced imaging fellow there at Children's National as well. And Dr. Craig Sable has been involved with helping them prepare for this case. He's professor of pediatrics and director of the echocardiography lab there. And then from the Uganda Heart Institute, I think we'll have Dr. Judith Namayanga, who is a consultant pediatric cardiologist at the UHI, as well as a pediatric cardiology fellow there, Dr. Nestor Mbabazi, who's also at UHI. And then on the line, we have several other experts that we've invited on because this case does step a little bit outside our comfort of cardiology. And so we have a number of people who have been kind enough to devote some time from rheumatology, cardiology, infectious disease, both here at Cincinnati, at Minnesota, and kind of across the globe. I know we have people from Brazil and Uganda, and I think Australia and East Timor and New Zealand on the line too. So I want to thank everybody for being here, and we can get started with your team, KK, at Amrita.
Yes, sir. I'll start sharing my slides.
Perfect.
Are the slides visible?
Yes.
Yeah. Can we start?
Go ahead.
Yes. So good evening, everyone. So we are here to present an interesting case of an 8-year-old female child who was hailing from Uganda. She's malnourished, weighing only 21 kilos with a height of 103 centimeters. She was diagnosed with rheumatic heart disease with severe mitral regurgitation in October of 2023. She has a background of recurrent hospitalizations for febrile illnesses where the reasons were not known. She was advised penicillin prophylaxis there, but was not very compliant with a treatment. She was well preserved with no limitation of her functional activity. So on her arrival at Amrita, vitally she was afebrile. Her heart rate was around 100 beats per minute. She was regular in rhythm, a normal pulse volume. Saturation was 100% with the blood pressure, the right upper limb being 92 by 60 millimeter Hg. Jugular venous pressure was not elevated. There was no pedal edema, though there was a liver palpable 4 centimeters below her right costal margin and a spleen tip palpable. So this was her 12-lead ECG with normal standardization. Showing a normal sinus rhythm with a heart rate of around 100 per minute. There's a left axis deviation with significant inlay enlargement, as you can see with the P mitral that is observed. And also significant biventricular forces have been noted with Q waves in V5 and V6 indicating volume overload of the LV. This was a chest radiogram done in PA view showing a normal situs solitus with cardiomegaly of CT ratio more than 50% of LV predominance. You can also see the significant LA dilatation as a double shadow that is seen on the right heart border. And also, as the pulmonary vascularity, you can see this prominent pulmonary vascularity of the upper lobe, which is almost equal to that of the lower lobes, indicating cephalization, which suggests of stage 1 pulmonary venous hypertension. So then we did an echocardiography for her. There's an apical 4-chamber view showing a dilated LA and LV, where the AML is thickened and it is moving into the LA, where the PML is also thick and it's pointing downwards with restricted mobility. As you can see, there is severe eccentric MR through a large zone of non-cooptation with no mitral regurgitation. Moving on. So this is a parasternal short axis showing that all the leaflets, both AML and PML, are thickened with commissural thickening as well as noted. We can see there's a pan-commissural mitral regurgitation noted predominantly on the lateral aspect of the mitral valve involving A1P1 and A2P2. So her LV dimensions, her internal LV IDD was around 54, which is up to a Z-score of +4, and IDS is a Z-score of +2.5. And then there was no other valvular involvement noted. Her LV functions are preserved with an ejection fraction of 72%. So when we did our baseline labs at Amrita, we found that she was anemic with a hemoglobin of around 8.9 grams per deciliter, her platelet count within normal limits. Red cell indices were more pointing towards a normocytic normochromic anemia as pointed out by the peripheral smear. Though her thyroid function tests were within normal limit, she was IgM positive on arrival, but she was asymptomatic from that. No, interestingly, we noted that her renal functions were deranged. Her urea was 89, creatinine was 1.25 mg per deciliter, and the inflammatory parameters, ESR was elevated of 109 millimeter per hour. Her CRP was negative, and her ASO titer was 200, which is borderline. Our lab parameters of less than 200 is considered normal. So for the deranged renal functions, we got a nephrology consultation here. We found the ultrasound abdomen and KUB showed that there was a bilateral echogenic kidneys with maintained corticomedullary differentiation. So as per nephrology protocol, we followed meticulous fluid balance, but there was no serial renal functions were monitored, but there was no improvement in any of the renal parameters. So to further investigate, we did a phosphorus level which was elevated, the uric acid levels were elevated, and also there was acidosis as noted by the low bicarbonate levels, suggesting that there was a chronic renal pathology in the background there rather than an acute event. Her renal status was dysfunction was more prominent than her cardiac standpoint. For her hepatosplenomegaly, anemia, and for the elevated ESR, we did a hematological workup which showed that the high performance lipid chromatography had no abnormal hemoglobin peaks. Ferritin was elevated of 349. There were iron studies of TABC and serum iron were within normal limits. LDH was elevated up to 368. Retic count was high of 2.28%, though her direct Coombs test was negative. So on day 12 of her hospital stay, she developed high-grade fever spikes, which were lasting for more than 72 hours, which were persistent and were not responding to the antibiotics, which we had started empirically. So at that point, we did the repeat parameters showing that ESR was 111 millimeter per hour. Her CRP, which was 31 to begin with, jumped to 67 within 24 hours. Titers of ASO were again 200 borderline. Total count was 6,100 with no predominance of neutrophils or lymphocytes. Her blood, urine, as well as the throat swab cultures were sterile. So subsequently, thinking of acute rheumatic fever and rheumatic activity, we started the child on oral steroids. Surgery, we was deferred at that point in view of ongoing inflammation and renal dysfunction. We continued her on benzodiazepine penicillin prophylaxis, and the patient went back to Uganda. She was referred 6 months later back to us. The interim period at stay at Uganda was uneventful. On arrival with us, she had no limitation of activity. She had no signs of congestive cardiac failure. Again, her baseline lab showed persistently elevated renal parameters where urea of 143 and creat of 1.26. Her ESR was still high of 100. ASO titer still 200 borderline, and CRP was negative. On day 2 of stay, this time she had one high-grade fever spike of 102 degree Fahrenheit, during which time the dengue IgM was positive, or the platelets are within normal limits, and the blood smear showed ring schizon for malarial falciparum. So she started on artemisinin combination therapy, and the fever subsided after 3 days. So in view of this persistently elevated inflammatory parameters and this history of recurrent infection that she's been having during her admissions, and also the chronic kidney disease in the background, we thought of any primary immune dysregulation as an underlying cause. So we did our ANA immunofluorescence, which showed was positive 4+ with M2 and nucleosome antibody positive. We did our anti-dsDNA levels, which were 15.83, less than 10 being normal of our lab and 10 to 15 being borderline. Her beta-2 glycoproteins were normal. Lupus anticoagulant was negative, though her anti-cardiolipin IgM antibodies were elevated. The complement levels of C3 and C4 were normal, and complement functions were also within normal limits. We did a CT brain to rule out for any looking for any neural calcification. We found only bilateral choroid plexus calcification. Of the evaluation, showed no evidence of uveitis. So for the management, we wanted to do a whole exome sequencing for the child as well as a renal biopsy, but due to our limited budget, we were not able to do so. Whole exome sequencing to cause for any monogenic cause of SLA, and also for looking for any primary immunodeficiency genes. Renal biopsy, because of this chronic kidney disease in background without cause, we wanted to rule out any nephritis in the picture. She was initiated as a management on oral steroids at 2 mg per kg per day after consultation with the rheumatology department along with hydroxychloroquine. Serial improvement renal parameters as well as the ESR was noted on the steroids, but echo showed no much significant change in the mitral regurgitation, and again surgery was deferred at this standpoint. So as you can see, the line graph showing significant drop in the creatinine values after initiation of steroids. Similarly, as observed with urea, and her ESR, which was 94 during initial steroid, had dropped down to 68. So in July 23, 2024, recently she was reassessed at Uganda when she was admitted with them with heart failure. That time the ESO titers at that hospital were 800, ESR was 86, still was persistently high. She was managed with Lasix, aldactone, enalapril, and carvedilol. Though her vitals at that time point were heart rate of around 130, blood pressures were 97/57 with a mean pressure of 74. Saturation was 94% on Drumer. And echo parameters had no much difference. She continued to have severe mitral regurgitation with significant LV dilatation. But the RVSP of noted here was about 88. And then her peak PR gradient of 34 was noted, though we did not have any documented pulmonary hypertension when she was at Amrita.
Wonderful.
So,
Sorry, go ahead. I was going to ask, there was one question I had through, thank you for the presentation. There was one question from the chat that I wanted to voice is, was there a urine microscopy obtained at all? And if so, was there anything that was a remarkable finding on that you might recall?
So can you please repeat?
Was there a urine microscopy obtained?
We had done a urine microscopy. We didn't have any proteinuria.
No proteinuria.
There was no proteinuria nor RBCs in urine.
Okay. Thank you.
I have a quick question. Are we calling this a flail leaflet, or is it just poor mobility of the posterior leaflet?
So it looks like a combination of both. It was very evident that the mobility of the posterior mitral leaflet is quite restricted. At the same time, we could see the AML like go beyond the level of the annulus well into the LA. So it's a combination of both, where we have restricted PML mobility as well as probably a minor caudal rupture, which is causing sort of the flail characteristic of the anterior mitral leaflet.
Thanks.
Thank you.
Yeah, this is Craig. From our review of the study, I thought there was a pretty significant portion of flail, definitely A2 and probably A1 as well.
Thank you. I wanted to take a chance to pass it to the team at the UHI. Dr. Judith, Dr. Nestor, I see you're on the line here. Is there anything that you'd like to add to kind of the clinical course before the transfer to Amrita? And my question also is, where is this patient from in Uganda, and kind of what's the burden of their travel down to Malago?
Hey, so good morning for you and good afternoon for us in Uganda. This is Judith. So we first saw this child, and of course, one of the things that ran into our minds were most common things occur most commonly. And RHD is top on our list. So that's why we thought it was rheumatic heart disease. Truly, there was that prolapse of anterior mitral valve leaflet, significant mitral valve regurgitation, chamber dilatation, and of course, as you've classified the MRJ from the parasternal short axis view. So we thought that this is a child that would benefit from mitral valve repair, preferably at that time, because the leaflets, yes, were thick, but not so horrible. And so this would give her another opportunity. And so our sponsor then was able to link her up, of course, with our help to Amrita and have a valve repair, which did not happen. And so when the mother reported that they had sent them back without surgery, we had a lot of questions. And but we respected the decision and said, okay, let's watch and see what happens with this with a steroid care. However, I think by the time I sent that report to Prof, to KK, the child was back in heart failure, overt heart failure, Anasaka had renal failure. We had involved our renal team. She was on the general hospital. So we would see her together with Nesta. Nesta is our fellow that completed. So we'd see her at the UHI, but the family could not afford all the costs at UHI. So they were hospitalized on 16C, which is the general Molavo ward, cardiology ward. So, but she literally had signs of heart failure, had renal failure, which later resolved with involving our teams. What struck me most is that at that point we saw her, we thought she now had a relapse. We thought this is now rheumatic fever. Is it really still what they think, or this could be a relapse? And that's why we ran tests. We ran the anti-lysine O titers, and we repeated the C-reactive protein and the ESR, as you've seen on that report. So the ASWOT was quite high. I mean, 800 is 4 times higher than what was recorded in Amrita. And I shared with Prof and said, yeah, we thought it was SLE, we thought, but I really thought it's RHD. The fact that now the ASWOT stands out above our normals for Uganda at 380, that was significant from my side. And the question is, even when it's SLE, are we going to leave this valve like that? The child is symptomatic. Are we just going to watch? I know that the DNS was positive, the anti-D was positive, I mean 15 units, that was high, but are we going to leave this child that way? She had a funder who was willing to support her. Yeah, thank you. Nesta could just comment on where the family is coming from, the distance, if you do remember. Thank you.
Thank you very much, Dr. Judith. Hello?
Hi, Nestor. We can hear you.
Okay, thank you very much, Dr. Judith. Yes, I managed to participate in the treatment of this child on their last admission. They come from the eastern of Uganda, something like Mbale, in the eastern of Uganda, some good distance from Kampala. So they stayed about 1 month in the hospital, and it was the father looking after the child. It was quite, of course, straining for the family. The mother was at home with other young children. Yeah, but the child had heart failure at that time and also kidney injury, which with the help of nephrologists, we managed to pull out of the kidney injury, and also we managed the heart failure. And the child, by the time we discharged, the child had actually stabilized. It was now out of overt heart failure, and we sent them home to continue with oral medications for heart failure, and we continue to review them in the outpatient clinics. But generally, the father was definitely strained financially, and was actually requesting to go home now and then when she was in hospital because of the financial constraints. So they are not doing very well financially, and even reviews are also a bit of a challenge. Sometimes she delays to come in for review. Yeah, but we keep in touch. He keeps on calling me on phone, updating me how the child is, and they are still taking their medications for heart failure. So, but they live that far, like east of eastern Uganda, and the father definitely is looking for help, looking for a definitive solution for this cardiac disease, if there can be one. But the child is there taking medication.
Thank you both very much for that insight. How about right now, let's, if it's okay with you, the team from Amrita, we might have you stop sharing and we will pass it to the team at Children's National to kind of share what they've prepared for this.
Yes, sir, sure. We'll stop sharing.
So I'll start sharing my screen in just a second. All right, I think. See, are you all able to see my screen well?
Yes.
Okay, perfect. So good morning or good afternoon, everyone. I am Jonah Collado. I'm one of the first-year cardiology fellows here at Children's National. And our team has been tasked with sort of the challenging yet exciting task of guiding us through the rest of the discussion in terms of next management steps and approach to the care of this patient. We thought that before doing so, it would be helpful to sort of review briefly some background information in terms of rheumatic heart disease, especially for those of us who are not as exposed frequently to patients with rheumatic heart disease, to sort of provide a little bit of educational background. Let's see. All right. And just to briefly summarize all of this in the context of the patient that we just saw, we thought it would be helpful to include a slide going over that, knowing that this is an 8-year-old female with severe rheumatic mitral regurgitation, medically managed heart failure, renal dysfunction, and a history of recurrent febrile illnesses, who was then evaluated for ongoing fevers with elevated inflammatory markers and persistent renal dysfunction, with ultimately a workup that was concerning for signs of early onset lupus versus other autoimmune disorder, was treated with steroids and hydroxychloroquine with downtrending ESR improvement in renal function, then with a most recent follow-up visit that revealed sort of the echo findings that were discussed, and the laboratory data with increased ASO and ESR as well. With this patient, I think our colleagues at Amrita brought up wonderful discussion points that we hope to sort of address throughout the rest of our presentation. So doing a very quick overall review of rheumatic heart disease, I think it's important to note that it is by far one of the most important forms of acquired heart disease in children and young adults that live in resource-limited countries, making it a major cause of cardiovascular disease there. It accounts for approximately 15% of all patients with heart failure in endemic countries. The prevalence is estimated to be about 54 million, and it predominantly affects those living in poverty with inadequate access to healthcare and unchecked exposure to group A streptococcus. The importance of socioeconomic factors is, I think, further underscored by the fact that rheumatic heart disease is an illness that is not commonly seen in industrialized countries since the mid-20th century, but continues to be very prevalent and endemic in countries throughout Africa, Asia, South America, and resource-limited communities in Australia as well. I think it's also important to note that longitudinal registries have shown that in these areas where it continues to be endemic, patients tend to present at a younger age and with complications at the time of presentation, with advanced disease, and then suffer significant morbidity and mortality for this reason, which very well correlates with the case that is being presented today. As we know, rheumatic heart disease itself is defined as permanent valve damage that comes from an episode or multiple episodes of acute rheumatic fever. I don't want to necessarily spend a lot of time going over the Jones criteria, but just wanted you to have a quick refresher of what those were, as those are useful in thinking about acute rheumatic fever, and then emphasizing more specifically when we think about recurrent ARF and that how that may be related to the case presentation of our patient today, and sort of thinking about the criteria that go into recurrent ARF.
Hey, Jonah, I would just add that having been an author on the Jones criteria, I can say without any pause that they're probably not that useful and not that good. I mean, they're as good as we have, but really in a case like this, it's still a clinical diagnosis, and there are clinical conundrums, and there's a lot of people around the world and trying to figure out a better way to diagnose rheumatic fever, because clearly this case highlights the challenges of trying to use the Jones criteria when there's so many limitations to it.
Yep. Thank you for that, Dr. Sable. So I think this next slide highlighted very nicely sort of the chain of events that happen when there's a first episode of acute rheumatic carditis or acute rheumatic fever that leads to carditis, and how it can then evolve to leading to rheumatic heart disease. So with the first episode of acute rheumatic carditis, going down the chain of events, if there is, during that initial insult, severe or fulminant inflammation, sort of two big buckets can happen, whether you develop imminently or acute severe chordal and leaflet inflammation that then will lead to acute severe mitral regurgitation, or from that first initial episode developing moderate chordal and leaflet inflammation that then sort of sets the stage for repeated episodes of acute rheumatic carditis, and then leading to mitral leaflet thickening, retraction and fusion of the commissures, which will in turn lead to sort of that mixed picture of mitral stenosis and mitral regurgitation that is more often seen in older patients, usually between the second and third decade of life. If after that first episode of acute rheumatic fever, there is just a mild to moderate inflammation that usually tends to be subclinical and very often a misdiagnosis or just not identified because the patients don't present with symptoms, there can be a path to recovery. But then if in turn there are repeated mild insults from acute rheumatic carditis, then the chronic insults start to develop with chordal and leaflet inflammation, and then matting fusion and leaflet of the commissures. In older age is when you'll see a more non-pliable calcified valve with significant mitral stenosis. And then in younger patients, you'll see a lot less calcification. And I think to Dr. Sable's point, and in the context of our patient today, it becomes very challenging to sort of differentiate and diagnose acute rheumatic fever and the differential diagnosis that may come with other inflammatory or infectious etiologies. If we think about it, the clinical presentation for acute rheumatic fever in subtropical and tropical nations where there's fever, arthritis, the differential diagnosis becomes very broad within the buckets of inflammatory conditions, but also infectious conditions, mosquito-borne illnesses. And it is a diagnosis that can be very easily missed. So that overlap of acute rheumatic fever, other potential inflammatory or infectious etiologies, and then the relation of rheumatic heart disease becomes sort of muddied. Going into a little bit more of the clinical presentation itself, like we mentioned, the mitral valve tends to be involved in nearly all cases of rheumatic heart disease, including those with other affected valves. The sort of proposed mechanism, we kind of went over it, but a lot of inflammation in the annulus itself leads to annular dilation, chorditis leads to chordal elongation, and then valvulitis will lead to the typically seen anterior mitral valve leaflet prolapse and pathologic mitral regurgitation. In patients younger than 20 years of age, isolated mitral regurg is the predominant lesion that we see. The aortic valve can be involved in approximately 20 to 30% of cases. The tricuspid valve can also be often involved, but usually presents with subclinical disease, and it's only noticed when surgery is needed. And pulmonic valve involvement tends to be very rare. We briefly touched on this as well, but in many cases, patients will present with advanced or severe mitral regurgitation, and therefore with associated complications that come with that. A lot of patients will present with new onset heart failure, atrial fibrillation, stroke, recurrent carditis, and even infective endocarditis. When we think about the indications for surgery and all of this only in the context of mitral regurgitation, which is what most applies to our patient today, surgery is definitely indicated in symptomatic patients who have severe mitral regurgitation in the absence of severe LV dysfunction, and severe LV dysfunction is defined as an LV ejection fraction less than 30%. The reason being, when there is severe LV dysfunction, a more in-depth conversation needs to happen on whether surgery is the best next step for the patient, sort of like outweighing the risk benefits of intervening in LV that's already pretty severely affected. In patients with severe MR that are asymptomatic, surgery is indicated when there is mild to moderate LV dysfunction, and that mild to moderate category is with an EF ranging from 30 to 60%. When there is no LV dysfunction, a conversation should be had in terms of if the patient is a good candidate for surgical valve repair, then usually surgery is recommended if we know that mortality will be low. If mechanical valve or replacement is the option for patients like this, then a more in-depth conversation needs to happen and sort of outweigh risk benefits. In patients with moderate MR that are symptomatic, we know that they will likely progress to severe mitral regurgitation and therefore warrant very close follow-up and continued reassessment of the severity of the MR to then determine when they become surgical candidates. So all of this, putting it back into our patient, who, this is sort of the summary once again, the most recent echo findings, we know severe mitral regurgitation and continued hyperinflammatory state. What exactly are we dealing with? And I think it's sort of a hard question to ask and would love, I think, to open it up with this little poll that we created to see what are we thinking at this point, get all the audience involved, and then hopefully open it up for discussion with some of our experts who are joining us today. So if you can go to the poll.
All right. And Jonah, thank you for that. I just wanted to add a couple of things. I think that was great. So we deviated a little from the typical format, just because I think before we talk about kind of what our management would be, it'd be best to go over our diagnosis and the broadness of it. So feel free to use the poll everywhere if you'd like. We've put in a couple of things that were on our list, or chime in just on the Zoom.
Hey, Jonah, the only thing I'm seeing is it's waiting for you to open up the poll everywhere.
Oh, okay. Let me
Yeah.
see. Oh, there we go.
Awesome.
Thanks.
Mhm.
I'll just give a couple minutes. But I think we can already start seeing where the majority of people are sort of inclining in terms of diagnosis for this patient. Right.
Yeah, I think we can probably move forward. I think we got a good
Okay.
consensus here.
So yeah, I think when we thought about it was, is this progressive rheumatic heart disease? Could this just be rheumatic heart disease with recurrent acute rheumatic fever? Is there another autoimmune or inflammatory etiology involved, or just a combination of all of the things above? And I think this, at this point in time, would be a good time to open it up for discussion, to hear sort of some of the thought process behind why do we think it's a multi-factorial picture that's happening.
And I can add a question that I had too, and this might be too, if there's a couple rheumatologists or other kind of non-cardiac experts on the line, is, does this patient kind of fit criteria with SLE? That's something that I have kind of put in the back of my mind, and I can't quite remember what those are anymore, knowing that this is a partial case presentation.
All right. Hi, good morning. Can you hear
Good
me?
morning. Yes.
I'm Kim Newboo from Cincinnati Children's, pediatric rheumatologist and co-director of the Lupus Center here. I think the first thing is, lupus is not just a laboratory diagnosis. It's taken, we look at the patient's exams, the story, and then we, have the laboratory backing with that. So I have several questions for the patient in terms of her physical exam, like what was found in exam that supports a diagnosis of lupus. Yes, we do have the serologies that look like it. Isolated valvulitis is rare in lupus, but that could happen. More commonly, it would be pericarditis when we think of the cardiac effects. And then that more likely goes with more like long-standing disease when you have like valvulitis. Very rarely, and I did look at the literature just a little bit to see what's the co-occurrence with rheumatic heart disease. That's lupus and rheumatic heart disease. Extremely rare. Basically, very, very few case reports. But just to say, so in her case, I would think it's very rare for her to have both. I would really think that we would need to explore the lupus diagnosis. And also, yes, rheumatic heart disease is endemic there, but then it also, with a diagnosis of lupus, you want to make sure that the patient's level of inflammation, systemic inflammation, is at least well controlled or better controlled before you do a surgical intervention. The reason being that post-surgery you could have complications from hyperinflammation, and then you might have to modify immune therapy around the time of surgery even. And so if there is information about, the physical exam findings, alopecia, distinct rashes, joint symptoms with the arthritis, the criteria for lupus are not necessarily diagnostic criteria. They were derived initially more for research purposes. Those are more recent criteria is actually helpful when we're trying to tease out this kind of circumstance. In essence, does she check most of the boxes for what we would call lupus, particularly if we're trying to enroll her in a study? So we could go by that and make sure and see, what else does she have. I found her kidney dysfunction interesting, but even more so is that she didn't have proteinuria, and it sort of got better with the acute management. So basically thinking this is more an acute kidney injury, but it would have truly been helpful to still get that kidney biopsy to put things to rest and actually give us a diagnosis. Then the fourth thing is whether this is more monogenic type lupus or earlier, onset lupus because of her age. And if we're assuming that most of her symptoms started well before she was 8 years of age, just given the extent of her valve disease, I agree that, probing further, I know someone had asked about immunoglobulins in the chat and other indicators that this might be a more monogenic cause of lupus-like disease would have been good to do, particularly because she's atypical in presentation.
Thank you very, very much.
Sure.
Dr. Okello, I see you have your hand raised.
Yeah, thank you very much, Hank. This is Jocelyn. I'm joining together with Amy. Yeah, this is what we think. On a normal day, this would be, rheumatic heart disease, most likely with an ARF episode. And so we have, some questions. Number one is in terms of the physical examination, like, did we have any fistures to suggest SLE, from the malar flash and any other findings? But then this is, Hank, Kelsey, and others from reading up. So the lab markers, talk of Anna and all the others, how specific are they to SLE? And do you have any literature to, have these been checked in any RHD cohorts? Do we know that they can't be raised in RHD ARF, and so that when we find them raised, we'd have to think of alternative diagnosis? Thank you.
Thank you. I'm not sure if anybody can speak to kind of the collection of lab criteria here and how specific those get. I think in my reading, if you get enough of them, the specificity certainly gets up to the 95 to 97% range. And I think the renal biopsy that I read certainly can be helpful to add weight to the diagnosis. But also, as Dr. Ogbu kind of mentioned, it's also, I think, a little bit of a prognosticator too, depending on what you find on the renal biopsy. And that certainly can play into what type of surgical decision you want to make for this type of patient.
I think Dr. Suma Balan is on the line and wanted to
Yeah.
give. Thank you.
Yeah. Yes. Hi. I've seen her during the admission, the second admission, when the fever was persisting and there was all this query. So I think when I saw her, the ANA was already done and it was strongly positive. She did not actually have clinical findings, the typical clinical findings of SLE. She did not have any significant rashes that I can remember. And there were non-specific joint symptoms, nothing very typical here. But because of the strength of the ANA positivity, we did her, ANA profile. We looked at the extracted nuclear antigens. We looked at her complement levels. We looked at some other features. And so there was some evidence from that she had some more antibodies to corroborate to the diagnosis. But I would agree that it is very difficult to pin a diagnosis of lupus on this girl because to me, we needed to get to know her a bit more. A renal biopsy would have been useful, but funds were short. We couldn't actually undertake that. And her complements were normal, which something that we can see in monogenic lupus. It's when we do the total hemolytic complement is when we might find a difference compared to the usual C3 and C4 that we check for disease activity in these patients. So at that point of time, with the evidence I had, other than considering adding hydroxychloroquine along with the steroid she was getting, I really couldn't justify doing any more. Renal biopsy definitely would have been very helpful. It would have told us whether there is SLE or not, for sure. We rarely do a renal biopsy to make a diagnosis of lupus. We usually do it to assess the degree of nephritis rather than make a diagnosis of lupus. So I think this would have been an instance to do a renal biopsy to also look for a diagnosis of lupus rather than anything else. Whether the malaria, the infectious process in her body stimulated antibody formation, autoantibody formation, which might subsequently go away, is also a possibility we have to consider here. That cannot be entirely ruled out, and time would answer that question. Now, the only other thing to say is that patients we have had with lupus and mitral valve disease have had valve changes identical to what you see in rheumatic heart disease. So both in antiphospholipid disease, whether it is primary or secondary, whether it is lupus valvulitis, the valve changes we've seen are almost identical to what you see in rheumatic heart disease. So that looking at where she comes from, the possibility of RHD is higher for sure. The story background is higher for RHD for sure. Her age, however, the strength of those antibodies would make you want to rule out the possibility of an alternative diagnosis, but that cannot be done unless the other tests are also done. Now that so much time has flowed down the bridge, I guess we should probably recheck her autoantibodies. That would also help us to look at what we're dealing with from a diagnostic point of view. I hope that's useful.
That's very helpful. Thank you, Dr. Suma. I wanted to kind of get back a little bit. I guess I should open up. Does anybody else have anything that they might kind of contribute? I have a couple specific questions to get back to what a valve intervention might look like for this patient.
Yeah, I think we may have some of that on a couple more slides too.
Wonderful. Go for it.
I know a couple people had their hands raised while we go to that slides, but
Judith, do you want to take one moment while they're going to those slides?
Yes, so I just wanted to, of course, re-echo what Jocelyn had said, that we typically thought it's rheumatic based on where the child is coming from and the family setting, of course, low-income countries, poor families, and then the typical echo findings. But just wanted to say that I've ever managed at least one 16-year-old who had lupus with the typical malar rash, which we didn't see in this little girl. Didn't see any rashes, had the typical joint pains that of course would happen in either of them, whether RHD with rheumatic fever, relapse. It's really a dilemma, and I hope we get some answers. Rechecking autoantibodies, yes, would be okay, but it still comes with a cost for the family. And the other issue is if it was just lupus alone, from my last experience of the child, a doctor's child I saw several years back, unfortunately lost her. It's progressive. The renal failure would be progressive. But this child resolved with those drugs and then got a relapse, pulls out when you get nephrology on. So it's something back for us. Thank you.
Thank you. And I saw a hand from Dr. Bryce Bierstead at University of Minnesota as well.
Yeah, thanks. I agree with everything that's been said. I'm a pediatric rheumatologist. I would comment that the sort of commonality between rheumatic heart disease and lupus and related diseases, antiphospholipid syndrome, mixed connective tissue disease is also in the differential, is the formation of autoantibodies. And I think the disconnect between the very high SED rate and lowish CRP initially suggests that the patient has hypergammaglobulinemia. That's why I was asking about that. If it's possible to look for not what are called non-criteria antiphospholipid antibodies, so not beyond beta-2 glycoprotein and cardiolipin, including antiphosphatidylserine and so forth, that could be helpful. Those can drive valvular carditis like this. But ultimately, I don't know that it matters in terms of management. The patient is forming autoantibodies, and immunotherapy directed at that underlying pathogenesis would be important.
Thank you very much. Okay, Dr. Brown, do you want to return to you?
Sure, yeah. Jonah, if you want to go through some of the options we thought of for medical management.
Yeah. So, yeah, that was a nice segue to kind of continue going over the management alternatives that we had discussed. In this sort of like complicated picture, would the first next step be address the inflammation before considering any surgical intervention? Would an additional course of steroids be beneficial? Plus minus considering the use of IVIG or other additional immunomodulators. Granted, further workup would be warranted to then determine what would be the most specific and targeted therapy in this case. In terms of medical management of her heart disease itself, just continuing to manage her heart failure and continue to defer surgical intervention would sort of be like that first bucket. The second bucket, do we control the inflammation, waiting period, and then proceed with surgical intervention? Thinking about surgical intervention into two big buckets, whether it could be valve repair and this valve being amenable to valve repair, versus this would be a patient that would warrant valve replacement, which then leads to all of the sort of downstream complications that come with that in the setting of needing anticoagulation therapy, her renal dysfunction, and all of those associated factors that this patient is presenting. And then sort of as a third option, now that with her most recent visit, her renal function was in sort of a better control or relatively better control. And like we nicely mentioned during our discussion, was this just more of like an acute kidney injury that has recovered? Would this be the right time to sort of go for a surgical intervention, whether that be valve repair or valve replacement? And I think I want to continue to once again open it up for further discussion in that realm.
Hey, this is Craig, and I helped Jonah and Kelsey put this together. I do think that we've kind of done the anti-inflammatory treatment a couple of times, and I mean, I still think this is most likely rheumatic heart disease, and I do think the valve is likely amenable to repair. And to me, the only question is how can we do the repair safely, not if or what. Not if we should do the repair, and the when is as soon as possible. That's my opinion.
I think one other thing we had talked about just from a high resource center for from our side of things for management would be backup from nephrology, other sources for potential, even though kidney function is improved, just the high risk of surgery and the potential for dialysis afterwards would be another consideration.
Dr. Ogbu, I see your hand up, and then I had a couple thoughts, and whoever else is talking too, go ahead.
I was saying, just to echo what Dr. Brinstead said, and Dr. Summer had put a note in the chat, this kind of case would need a longitudinal rheumatology follow-up truly to really tease out what's going on with her. I think repeating her antibodies is fine, but even malaria or dengue fever, I'm not so clear about, but malaria would not be the one to trigger these autoantibodies. And it's pretty endemic in Africa to have P. falciparum just lying around. And you might have a positive ANA sometimes, or the double-stranded DNA is very concerning in the context of her disease. There is, I know that it's been a challenge for the family to travel back and forth, but we have more pediatric rheumatology colleagues in Africa. And I know if Kenya is easier for them to get to, most people in Uganda go to Dr. Angela at Aga Khan in Kenya. And so that might offer the family the chance to have longitudinal follow-up at a really nicer, higher resourced hospital as well, and get the longitudinal care that she would need.
Thank you. Perhaps I can get some people connected. Go ahead.
Can I'll just summarize the whole discussion so that it's clear for everybody. So essentially, what we have currently, the latest report that we have is a clear-cut worsening of the patient's clinical condition where she presented in heart failure, along with further rise in her inflammatory markers and an undeniable level of anti-streptolizin O. Considering that she's from an endemic region, very prone to rheumatic heart disease, it's undeniable that there is some amount of rheumatic activity happening there, and the current worsening can be attributed to rheumatic reactivation or recurrence. And of course, along with management of the heart failure, anti-inflammatory therapy should be able to bring her to a slightly better condition to go in for a surgical intervention is what we would also think. And at the same time, if we look at reports that we have both of valve repair in acute rheumatic activity as well as valve repair in the setting of an inflammatory pathology like SLE, we know that the worse the patient's condition and the worse the renal parameters, the morbidity and mortality related to the surgery is going to be higher. So, the unit, whoever is going to handle the repair, will have to be prepared to deal with a slightly stormy postoperative course with, backup for, renal replacement therapy at the right point whenever it is warranted as well. And at the first time when we saw the patient, symptomatically, she was doing well. Like she was in class 1 or maybe class 2 at the max. But currently, that is not the case, and there is a clear-cut worsening of symptoms, and that would definitely warrant consideration of an intervention. Of course, looking at all the points that can bring in the safety element so that she recovers from the procedure well. And of course, from the discussions with respect to the SLE, the most plausible explanation seems to be that there could be an option of the recurrent infections, stimulating the immune system, unless and until we have more definitive evidence in the, either from a biopsy or from a repeat analysis of the antibodies to say that there is a clear-cut SLE process going on. So that is what I would take away from the whole discussion.
Thank you for that summary. I think that's fantastic. We're kind of at the hour mark. I know that some people might have to drop off, and I want to respect time. Is there anything else that anybody else kind of had to add here in the last little moments?
Yeah, I just had a quick question. I mean, this is kind of a Hail Mary, but did anyone talk to the interventionalist about a mitral clip? The anatomy, I'm not an interventionalist, but I mean, something worth thinking about given the high risk of surgery.
Hi, can I answer this, Hank?
That was Dan.
Dan, can I answer this question?
Yeah.
So, the mitra clip, yeah, it sounds fancy, but it's simply not an option for rheumatic heart disease, because the mitra clip essentially converts a single orifice mitral valve to a dual orifice mitral valve and brings AML and PML together. Now, here the mechanism is way more complex. The mechanism of mitral regurgitation, as you might have seen from the echocardiogram, was the PML is really fixed across the entire annulus. And the AML goes beyond, the tip of the AML goes beyond the PML, and there is a pan-commissural leakage. So just getting one part of the two leaflets to come together will not save the situation. Then, of course, there are the challenges of mitra clip. Mitra clip needs a minimum weight. The systems that you need to deliver the mitra clip are very large. You can't do it in a child. So for those reasons, it's not probably a good option for this particular patient.
Thanks.
That's helpful. Thank you. Anyone else with any kind of last second thoughts or considerations?
The only other thing we could offer is, Judith, will the patient be available when Dan and our team are there to do another time point, get another echo, and maybe reassess when since we'll have and then Dr. Sinha, our surgeon, will be there as well from the 4th to the 8th. Maybe we can reevaluate the patient together then.
Well, we can organize for the family to come in and we reassess. Yeah. But I really thought that a repair would be beneficial.
Yeah, I agree. I just think that the key question in this is how to do the repair safely and have the appropriate renal support and dialysis support as backup if the child needs that. Ultimately, the repair will make the child healthier and lower risk for future kidney damage. But if we do the surgery and don't have the ability to support the kidneys for the first week or several weeks post-op, then it would make sense. So I think that kind of changes the equation. And so we'll, but I think we should discuss the case, and maybe Dan and Dr. Sinha and you can review the patient together and then update us all.
Yeah, I was going to add that.
Sorry, I was just
going to emphasize that inflammation needs to be controlled in the patient before we take up pre-surgery and even after, because if there's a chance this is lupus, it's likely she will flare in the post-op period. And so just making sure you have that rheumatology backing that can help you through that would be essential. We're seeing a lot of cases of cardiac disease in pediatric lupus in Africa from what we hear from our colleagues that are practicing there, mostly because, like you all know, we have not had a lot of pediatric rheumatologists on the continent, but that's changing. And I think leaning on the experience and honestly answering the question about what kind of serologic changes we would see in acute rheumatic fever might be something to touch base with Dr. Migo and the rest of them that have practiced locally.
Okay, so that sounds really good. We are going to get in touch with the family, get them back. The symptoms and the signs that we reported that happened way some time back. And so we can rerun those tests, but of course it all comes with a cost. we have pediatric nephrologists in the country. We have 2 of them, and we have access to renal replacement therapy. We can do dialysis in the Mulago National Referral Hospital for the children, but it still comes with a cost. But at least we have that backup. And if you could share the contact for the colleague in Aga Khan in Nairobi, that would be good, so that we could call them or have a brief meeting and agree on what to do. Thank you.
I can get you guys connected by email. I think that might be it for the conference. I appreciate everybody's participation. This has been nice, and it's nice to kind of step outside the world of the heart every once in a while and see the other body systems and how they contribute to things. So I really appreciate everybody. Let me there is a survey link what I can do. We're running a little bit out of time, but let me just drop something in the chat here real quickly. We're trying to collect data on this just to kind of inform what we're doing here with this program. And so I will quickly put this in the chat. And then I think we can all say our farewells if that's okay. Thank you, everybody.
Thanks.